morning, students. Today's class is on cephalometric analysis. Cephalometrics includes measurement description, appraisal of the morphological configuration and growth changes in the skull of ascertaining the dimension of line angles and planes between the anthropometric landmarks established by physical anthropologists and points selected by orthodontists. So it is nothing but whenever we treat an orthodontic patient, we will be taking an pre-treatment cephalometrics in which fixed and derived anatomical landmarks will be there. We will be measuring it and compare that measurement of that individual patient to the normal values established by an anthropologist, and thereby we can predict the growth of an individual, and the direction of the growth can also be predicted, and the treatment will be planned accordingly. So mainly it is implicated to study the skeletal, dental and soft tissue structures of craniofacial region. Again, cephalometrics helps in classification of malocclusion, and it aids in formulating the treatment plan and growth prediction of the individual, and it can also be utilized in research work. So for ideal cephalometrics, it should cover superiorly 5 cm above the sella turcica, and anteriorly we should be able to visualize the tip of the nose, and inferiorly it should be visible as per the implications given, and posteriorly we should able to see the spines of the first cervical vertebrae. So the cephalometrics was taken using a cephalostat. Ideally the individual should have 5 feet distance from the source of the X-ray radiation. So what is the goal of a cephalometrics? The goal of a cephalometrics is to establish anteroposterior and vertical relationship of 5 major cranial units. What are the 5 major cranial units? That is your anterior cranial fossa along with your cranial base, then your maxilla, then your mandible, and then so to get an ideal cephalometrics properly without any deviation, you should make the patient to stand in the natural head position. So natural head position is nothing but the person should stand in a relaxed body posture, and he should see a distant object at the level of his eye. That is, we have to make the patient to stand and in a relaxed position, and he should see a distant object so that his mandible will automatically align parallel to the floor. So this happens by the sensory data from the laburnus of the inner ear and modified by the visual inputs. So once you achieve the natural head position, then the cephalometrics has to be taken. So if the patient has an obvious asymmetry, what we will do is we will make a mirror in front of the patient, and we will be hanging a metal chain, and we will ask the patient to orient his head over the metal chain. Thereby, if any asymmetry is there, that will be overruled. So if the natural head position is not achieved and the cephalometrics is taken, the FH plane will be altered. Either it will increase or decrease accordingly. So to do a proper cephalometric tracing, these are the armamentarium that will be needed. That is, you have to have an acetate matte tracing paper and a sharp 3H drawing pencil and a masking tape, scale, protractor, a view box and dental cast to correlate the molar relation and the functional and occlusal planes. Before starting a cephalometric tracing, the first thing is the tracing will be done from outward to inward. The first thing is you will be tracing the soft tissue, followed by your cranial base and interborder of the cranium, frontal sinus and ear rods, and then your maxilla related structures, then your mandible related structures, and the correlating that structures along your cranial base. So color coding for your tracing is pre-treatment, usually you will be doing it in black, and the progress of the treatment we will be doing it in blue, and end of the treatment we will be doing in red color, and retention phase the tracing will be done in green color, so that you can appreciate the treatment progress of an individual. So before going to the tracing, you need to know the basic fixed anatomical landmarks. So end point is a nasion. It is formed at the junction of your frontal and nasal bone along the frontomaxillary suture. Then comes your anterior border of the maxilla, in which you have two significant landmarks, that is your anterior nasal spine and your A point. A point is the deepest point in the anterior border of the maxilla. Then you have your posterior nasal spine that marks the posterior extent of your maxilla. And then coming to your mandible, you have your B point, which is the deepest point in anterior border of the mandible. It usually from 3 mm from the cement enamel junction. And then in the anterior border of mandible, you have three significant anatomical landmarks, that is your PORION, which is the line demarcating the convex and concave surface of your anterior border of mandible. Then the deepest point of the mandible is your menton. Midpoint of PORION and menton is your gnathion. And the D point is the centermost point of your mandible. Coming to gonian, it is a derived point. We draw tangent to the posterior border of mandible and lower border of the mandible, and the point where both intersects is your gonian. Articular is the point where your sphenoid bone coincide with your condyle, that is your articular point. Sella is your deepest point in the sella turcica, that is your S point. So these are the unilateral landmarks that we will be discussing now. And the bilateral landmarks are your orbital, that is your deepest point in the orbital rim. Then your articular that we have discussed. And pterygomaxillary fissure is that will be coming here, teardrop shaped anatomical structure, and that's posterior superior point is your pterygomaxillary fissure. Then comes your PORION, that will be in the 12 o'clock position along the head of the condyle. So these are the things which marked in red color are your actual landmarks of the skull. The one which are marked in black color will be your secondarily derived from your anatomical landmarks. So among these landmarks, the difficult landmarks to identify are your point A, PORION, and the pterygomaxillary fissure. So corresponding soft tissue landmarks also you need to know. Glabella is the anterior part corresponding to the forehead and the junction of nose, and then you have your subnasal, and then you have your columella, pronasal, and then upper lip anterior point, upper lip mucosal side point A, and stomion superioris is junction of your oral mucosa and your lip, that is your vermilion border, and then stomion inferioris junction of your oral mucosa and the outer epidermis, that is your stomion inferioris, and this is your lower lip anterior point, and the corresponding A point will be called as A dash, and corresponding B point will be called as B dash, POC dash, menton dash, and gnathion dash. These are the respective corresponding soft tissue landmarks. So the most difficult point that was to identify is your point A. So to overcome that, we have one thing called point A revisited that you can construct. How can you construct this is, you have to draw a long axis along your upper incisor, and you have to mark your root tip of your incisor and mid 2/3 of the root, midpoint of that point, and correspondingly you have to extend that point here, and this point will be your A point, which is usually 3 mm from your apex of your root. This is how you have to construct point A if your anterior part of maxilla is very difficult to identify. Then comes your PORION. PORION is also the next difficult point to identify. Either you can take two PORIONs, that is your anatomical PORION or mission PORION. Anatomical PORION is this one. Mission PORION is a corresponding external artery meatus. We will be keeping ear rods, and that radiographic image that you get in your cephalogram can also be used as a mission PORION. So coming to the planes of your cephalometrics, point connecting S and N point will be your SN plane, and your porion to orbital will be your FH plane. The angulation between these two will be always 7 degree, and point connecting your ANS and PNS will be the palatal plane. Occlusal plane will be the line drawn connecting the posterior teeth which are in occlusion. Either you can consider your molars and premolars, and in certain authors will connect that line to the incisor tip. So this is called as your anatomical occlusal plane. When you don't consider the incisor and you connect only the tooth which are occluding, that will be called as your functional occlusal plane. Coming to the mandibular plane, it is a line joining your gonian and menton. So this is what your anatomical occlusal plane and functional occlusal plane. Coming to the cephalometric analysis, the first analysis, your STEINER'S analysis. The first landmark will be your SNA angle. How will you predict this? You draw a line connecting S and N point. This is your SN plane, and connecting your A point and N. This is your SNA. So SNA angle is the inner angle that you have to measure. Usually it is 82 degree plus or minus 2 degree. So if you have a prognathic maxilla, this angle is going to increase. If you have a retrognathic maxilla, the angle is going to decrease. So that it relatively tells the position of maxilla in relation to your cranial base. Same way, the SNB angle is angle formed between your SN and NB, and depending upon your relative position of your mandible in relation to cranial base, the angle will increase in case of class 3 skeletal base and decrease in case of class 2 skeletal base. And the difference between SNA and SNB is your ANB angle, and normal value is 2 degree plus or minus 1 degree. So ANB angle will be more for class 2 skeletal base, and ANB angle will be less for class 3 skeletal base. Then comes your SND. This also tells you the anterior most part of the mandible and its relationship to the cranial base. Then in STEINER'S, the mandibular plane will be the line joining gonian and gnathian. And this angle will be 32 degree for our average patient. If it is case of open bite, it will be increasing, and we will be saying that type of patient is a vertical grower, and this will be reduced in case of horizontal growers. Then your SN to occlusal plane, your functional occlusal plane, and the angulation of that occlusal plane in relation to your SN plane. This tells your relative rotation of maxilla, whether it is clockwise or anti-clockwise rotation of maxilla. The same is palatal plane orientation to your SN plane. Normally it should be 8 degree plus or minus 2 degree. Again, this also tells you the relative clockwise or anti-clockwise rotation of maxilla to the cranial base. Then comes your SL and SC. SL and SC is nothing but your orientation of your mandible, that is effective anterior posterior dimension of your mandible to your cranial base. So the midpoint of your anterior most point of your mandible, that will be transferred through a perpendicular line to SN plane. This is your L point. The distance between S and L will give you the value of SL. The same way, the midpoint of the condyle will be marked. From there 90 degree you should draw a line to SN plane, and the distance between S and E is your SC point. So this tells you the effective anterior posterior dimension of your mandible in relation to your cranial base. So coming to the dental parameters, you have NA and NA angular, NA linear. NA angular is nothing but you have to draw the long axis of your upper incisor, and you have to measure the angle formed between the NA line and this long axis. Usually it should be 22 degree. In the same way, you have to draw the anterior surface of maxillary incisor, and the distance between NA, and this line will give you the linear measurement of anteroposterior position of your maxillary dental structures, which implies the significant anterior position of your incisor in relation to your maxillary skeletal bone. The same way, NB and NB angular and NB linear. You have to draw the long axis of lower incisor, and the angle formed between NB line and this line will give you the relative position of your anterior dental structures to your mandibular bone. And the linear measurement, you have to measure from the labial surface of lower incisor to the NB line. The ideal value should be 4 mm. Interincisal angle is the angle formed between the long axis of upper maxillary incisor and the lower maxillary incisor. Usually you have to take the tooth which is most proclined. The ideal value of interincisal angle will be around 130 degree. Coming to the STEINER'S line, it is called as a S line, which tells you the facial contour of the individual. So it is a line drawn on the soft tissue contour of the chin to the middle of S, formed by the lower part of the nose. In a well balanced face, the lips should touch the line. If the lips are located beyond this line, lips are believed to be protrusive, and you say that as a convex profile. If the lips are placed away from this line, this is a concave profile with a class 3 skeletal base. So coming to STEINER'S analysis, these are the skeletal parameters and these are the dental parameters and the soft tissue analysis. Coming to the TWEED'S analysis, it has 3 important angles. The first one will be your angle formed between the FH plane and the mandibular plane. This is your FMA. And then the angle formed between your FH plane and the long axis of lower incisor, which is FMIA angle, and then the third one is the IMPA angle. So the sum of these 3 angles should be always 180 degree. And TWEED'S analysis is so special because it gives you a prognostic value of predicting your treatment plan and outcome. That is, if your FMA angle is greater than 30 degree, it says that the patient is a vertical grower and the treatment has to be done in such a way that your FMIA should be compensated for that, and your IMPA should not be more than 90 to 100 degrees, so that your stability of the treatment will be much better. Coming to WITS appraisal, this is nothing but you have to draw occlusal plane and you have to drop 2 perpendicular line from A point, that is AO, and 1 perpendicular line from B, that is BO. The difference between an AO and BO will give you the skeletal relationship of maxilla and mandible. If BO is behind AO, it is a class 2 skeletal base, or BO is ahead of AO, it is a class 3 skeletal base. Sometimes, if in case of bimaxillary protrusion, AO and BO will coincide, and in case of class 1 skeletal relationship also, AO and BO will be coinciding. Coming to Downs analysis. So Downs analysis, these are the skeletal parameters, that is facial angle, angle of convexity, AB plane and mandibular plane angle, and this Downs analysis will tell you about the growth axis of your mandible also. Dental parameters are your cant of occlusal plane, interincisal angle, incisor occlusal plane and incisor mandibular plane angle, and protrusion of your maxillary incisors. So first thing we are going to see is your facial angle. So facial angle is nothing but you have to draw your FH plane and then your N-POG line. So this N-POG line is line connecting your N and POG. Should be in the range of 82 to 95 degree. Then comes your angle of convexity. So measures the degree prominence of maxillary basal arch at its anterior limit, that is your point A, relative to the total facial profile, that is your APOG line, anterior to NA, that is the prominence of maxillary denture base relative to the mandible, that can be predicted with this. Then comes your AB plane. Measures the relationship of anterior ligament of apical base to each other's, that is your maxilla and mandible, relative to the facial line. Estimate a difficulty in obtaining correct axial inclination and incisor relation. The mean reading should be 4 to 6 degree. So this is the AB plane. This angle is your end pog line and the line connecting your axial inclination of your upper and lower incisor. This angle will give you the axial inclination of your incisors. Then comes your mandibular plane angle. This is Menton and then your gonian, and the angle formed between your FH plane and this mandibular plane. So this mandibular plane is going to increase if the mandible is going to rotate in this way. That in case of vertical grovers, this angle is going to increase. In case of D-bite, mandible is going to rotate this way and the angle is going to decrease. So Y growth axis indicates the downwards or forward position of the chin in relation to your upper face. So the FH plane and line connecting your sella and your gnathion. This is called as your Y growth axis. Mean reading should be 59 degree. Coming to the dental parameters, these are the dental parameters: cant of the occlusal plane, interincisal angle, incisor occlusal plane angle, and incisor mandibular plane angle, and your protrusion of maxillary incisors. So then the planes that you have to always remember in cephalometrics is your, I have discussed this already also, the FH plane, palatal plane, occlusal plane, and your mandibular plane. So coming to the cant of occlusal plane, this is how it is done. You have to mark your occlusal plane and then your FH plane, then you have to transfer this here and you have to measure it. Ideal value should be 9 to 10 degree, and it ranges, the difference ranges plus or minus 1 to 2 degrees. Interincisal angle is the angle formed between the line connecting the long axis of two incisors. And incisor mandibular plane angle, same as TWEED'S, like you have to draw your mandibular plane and your long axis of lower incisor, and this angle is your intermandibular plane angle, incisor occlusal plane angle. So this is your incisor occlusal plane angle. This is your occlusal line, and then you have to draw a long axis of lower incisor, and this angle is your incisor occlusal plane angle. So what this dental parameters tells us is relative position of your maxillary and mandibular dental structures over its maxilla and mandible in correlation with the cranial base. So coming to the linear measurement of protrusion of maxillary incisor, you have to draw the APOG line, and the distance from the labial surface of upper incisor to the APOG line in millimeter will give the relative protrusion of maxillary incisors. So these are the basic cephalometric analysis. As an undergraduate, you have to know, that is your STEINER'S, TWEED'S, WITS, and your Downs analysis. So this is an composite analysis, just to compile all the analysis that we have learned today. So what are the values that is relating the maxillary cranial structure, maxilla to the cranial structure? So in STEINER'S, it is your SNA angle, and so mandible to cranial base, it is your SNB and SND angle. So coming to the maxilla to mandibular relationship, that is your A and B angle that I have discussed already. Like this is like revision of the what we have discussed so far. I am compiling that in a single slide. Like a relationship here to your maxilla to cranial base was done by SNA. Mandible to the cranial base will be done by SNB angle. Intermaxillary relationship that we called as like SN A minus SNB is your A and B angle. Indicates the relative position of maxilla and mandible to the cranial base. In WITS, we have discussed already. It indicates the relationship between maxilla and mandible in relation to the occlusal plane. So in normal male, in class and skeletal base, it should be BO should be 1 to 2 mm behind AO. For female, it should be 0.5 to 2.5 mm behind AO. And in case of class to skeletal base, this BO is going to move little more backer because you have a retrognathic mandible. In case of class 3, the BO will either coincide with AO or ahead of AO because the mandible is going to move forward and downward. Coming to growth pattern, which will be predicted in TWEED'S, like with the mandibular plane and FH plane, your FMA angle will give you the idea whether the patient is a vertical grower or horizontal grower. In STEINER'S, again the same mandibular plane angle only, but here we will be taking gonian and gnathion. Coming to soft tissue, in STEINER'S you will be seeing the S line. So S line in a normal class 1 patient should touch both the lips. In case of convex profile, this will be protruded over the S line. In case of class 3, it will be placed away from the STEINER'S line. In rickets, you will be having the E line, which is a line touching the tip of the nose and most protruded part of your chin. Usually your lower lip should touch it. Coming to the hold-away soft tissue analysis. So soft tissue facial angle is nothing but your FH plane and line connecting your end POG. This is called as your soft tissue facial angle. This tells again your mandible is prognathic or retrognathic, and the facial angle. This tells you the convexity or concavity of the individual, whether the patient is in a class 2 or class 3 skeletal base. Then comes your H angle. H angle indicates your angle formed between the H line and your end POG. This angle should be 7 to 15 degree. This tells you the soft tissue convexity of an individual. Then comes your upper lip curvature. This indicates your position of upper lip in relation to your facial axis. Upper lip sulcus depth. H line from H line how much deep your upper sulcus is. This is a linear measurement. So this tells you the curl of the severity of curl of the upper lip. What does it mean? If the severity of curl of the upper lip is more, that means you have a thicker lipper. In case of thick lip, if you do extraction treatment protocol, the profile change will not be much appreciated. So soft tissue draping will mask your treatment outcome. So that part has to be explained to the patient. Upper lip thickness is from H line to your pointy A. This one is your upper lip thickness. Same reason, because when the thickness of your upper lip is more, the treatment change will not be much appreciated, which should be explained to the patient in advance. Upper lip strain will be there when there is a short upper lip, and protrusion of your upper incisor is much excessive, there will be an upper lip strain. So lower lip ahead of H line will be in orthognathic patient. In case of class 3, you will have a negative lip step. This is how you measure your lower sulcus depth. So again, soft tissue chin thickness should also be considered in treatment plan, because excessive soft tissue chin protuberance will give an appearance where the patient is having an protruding genium. So that area genioplasty may be advised if it is a skeletal thing. If no skeletal protuberance is there, only soft tissue thickness is there, we will not be advising for genioplasty. So the conclusion of today's class is you have to know the pre-treatment cephalometric analysis is an essential diagnostic criteria, so that you can plan the treatment according to the growth pattern of the individual. So when you plan a treatment according to the growth pattern of the individual, the stability of the treatment will be much better, and the retention protocol will be much easier for us. So aim of cephalometric analysis is to quantify objectively the extent to which an individual deviates from an aesthetic ideal. Cephalometrics alone cannot be used as a primary or scientific diagnostics tool in the correction of malocclusion. It is a diagnostic aid to determine the growth of an individual and the growth direction of an individual, and so that you can plan the treatment accordingly. You have to always correlate the cephalometric findings with the clinical findings of the individual, and then you have to plan the treatment for that individual. A two-dimensional cephalometric does not clearly portray the three-dimensional structure of an individual. That's why I am telling you have to correlate it with the clinical parameters. Orthodontic diagnosis and treatment planning is therefore considered as a more of art form than a science, and requires a careful evaluation of the available hard and soft tissue structures, along with your diagnostic cost analysis, patient chief complaint and requirement for the patient. Because once again I want to tell, like, malocclusion is not a disease, it is an treatment which is much concerned about aesthetic enhancement of smile of the particular individual. So that the patient concern has to be taken into account, along with all your diagnostic aids of photographs, diagnostic cost, and then cephalometric analysis and three-dimensional CBCT wherever needed. And then you have to formulate treatment options for the particular individual, and patient's compliance and acceptance of the treatment is must to arrive at a successful orthodontic treatment plan. Okay. Thank you, children.